Okay. Um, why don't we go ahead and get started? Good afternoon, everyone. Thank you for joining us for today's webinar. I'm Mario Machis. I'm a professor of economics at the Johns Hopkins Carey Business School and a member of the leadership team at HPHI, the Hopkins Business of Health Initiative. HPHI is a collaborative research community drawing from the Johns Hopkins Schools of Business, Medicine, Nursing, and Public Health. And we serve as both an incubator for interdisciplinary research and also as a convener of scholars, practitioners, and policymakers. Welcome again to our webinar, which is part of HPHI's webinar series, Conversations on the Business of Health. Joining me here today to co-host this webinar is Dr. Deborah Ravert, Debbie, who is a professor of emergency medicine at the Johns Hopkins School of Medicine. So Debbie and I are fortunate to be part of the Hopkins Business of Health Initiative, where economists like me have the privilege of interacting and working together with physicians like Debbie. And so at some point last year, Debbie and I started a little book club between the two of us. And the first book we decided to read was the one that we'll be discussing today. So that book is We've Got You Covered, Rebooting American Healthcare, written by our guests today, Amy Finkelstein and Liran Einav, economists at MIT and Stanford, respectively. Amy is co-founder and co-scientific director of J-PAL North America and also co-director of the Economics of Health program at the NBR, the National Bureau of Economic Research. She's an extremely influential scholar with research focused on market failures and government intervention in insurance markets, the economics of healthcare delivery, and much more. And Liran is chair of the economics department at Stanford, also very influential scholar, and it directs at Stanford in the NBR, it directs the industrial organization program. His research focuses on insurance markets, healthcare, including empirical analysis of adverse selection and moral hazard. In today's webinar, we go until 1 p.m. We leave some time at the end to address questions from the audience. Please use the Q&A function to ask questions, and Debbie and I will be monitoring that. So Amy and Liran, thank you again for joining us. Debbie and I would like this conversation to follow the structure of your book, because we really admire how you build the argument that you make step by step. But before we do that, we'd like to begin by asking for the 2-minute version of the whole case that you build in your book. So for someone in the audience who has not yet read the book, what is the core diagnosis and what's the core solution that you want people to take away? Amy or Liran?
Well, thank you, Mario and Debbie, very much for having us here. It's a delight to be here. It's funny, despite having written this book and given many talks about it, I think no one has literally asked me that very good question, but I will try and do it on the fly, which is, I think Liran and I came into this book or project that became a book, asking ourselves, obviously there are many problems with the US health insurance system, but what is it that it looks like we have been trying to do? And what is the goal? And that is revealed by all our past actions. And then just from first principles, not constrained by politics or by past decisions, obviously taking economic considerations into account, what would be the ideal functional system that we'd want to end up with? And what was both reassuring but also a little humbling about that exercise is that, as we say quite early in the book, by the end, the system we had designed from first principles is essentially what every other high-income country has. So it's universal, automatic, basic health insurance coverage subject to a government budget constraint, which can be decided on, by the voters. That's part one, universal, automatic, basic health insurance within a budget. And second, the ability for people who have the means and interest to supplement that with additional coverage in a well-functioning market. And there are differences on the details in many different country systems, and we talk about some areas where we're very sure which direction we should go in, and others where we think reasonable people could disagree, unreasonable people could disagree as well. But that's fun. Another way of saying it is, many times people come up to me and say, the sort of man on the street, why can't we just have universal coverage the way every other high income country does? Or why can't we just spend less on GDP, on healthcare as a share of GDP? As we say in the book on the second question, we don't think there are easy answers yet, but it turns out the man on the street was kind of right about the first one. And we can do this without increasing government spending.
Well, for not having had that question before, I think that was a great answer. Thanks so much for summarizing it. Early in the book, you focus on the pervasive risk in the United States of becoming uninsured. One thing we both found especially compelling is that it's not just a problem that affects people at the margins, like a small group of people, but a broader structural feature of the system, if we can call it a system itself. Can you explain why that risk is so central to your critique and why instability of coverage is such an important lens through which to understand the American health insurance system?
Yeah, that's a great question, in particular because well, I won't implicate Liran in this, but I'll say for myself, despite having been studying health insurance for 2 decades before writing the book, I don't think it was front and center in my mind how unstable or insecure health insurance coverage is and how pervasive it is. So basically, most people who have private insurance have that through an employer. And so if you lose your job or retire or change jobs to a job that isn't offering health insurance, you can lose your health insurance. And then a large share, I think about a quarter of the population, has Medicaid, the public health insurance coverage for low-income individuals, which was greatly expanded under the Affordable Care Act. And that is also highly unstable, not just because you have to meet the eligibility criteria, but because you have to constantly recertify that you are meeting those criteria. And so, the sort of fact that was, really shocking to us in writing the book is, there's a well-known fact that, prior to the Affordable Care Act, 1 in 5 Americans lacked health insurance at a point in time. And the Affordable Care Act, which tried to get to universal coverage, at least got that down to 1 in 10. But what was so, surprising and striking to us when we, worked on the book is that a much larger share of Americans, I think we estimate, 1 in 4 Americans under 65 will have some time period without coverage in a 2-year period. And when they lose their coverage, it's not just, for a week or a month as they're, on average, I think, they're uninsured for more than 6 months. Some people are uninsured, for more than 2 years. And so the reason that's so central is that, the very purpose of health insurance or any insurance is to try to provide some security and stability in an uncertain world, right? It's not, yes, we hope there are direct benefits of having the health insurance, but the primary purpose of health insurance, just like the primary purpose of fire insurance, is not to prevent fires, it's to protect you economically, give you some security if in fact you're unfortunate enough to have a fire in your home. The purpose of health insurance is to provide you economic resources in a moment of insecurity because you have health expenses. So the fact that health insurance coverage is itself insecure is just completely backwards and perverse.
So when people mention that 92 or 93% of Americans have insurance, I mean, that's statistically, I guess, at any given point in time, that's correct. But in many, many ways, that is also not correct or misleading.
Exactly. And in particular, both because the reasons why you may lose insurance can be precisely because you've gotten sick, for example, and can no longer maintain your employment. And then, the other thing I would say is the more we learned about the vast insecurity of Medicaid coverage, which, as I said, has been greatly expanded, this is what made us realize we really do need to start from scratch. We can't just, fix the gaps where coverage, or people are falling through the cracks, because it's precisely because we have this patchwork of different ways you can get coverage. Say, if you're low income, you can qualify based on age and income, or maybe, because you have a particular disease that gets you coverage if you have breast cancer, or, with in a particular state, but then, your age changes, your income changes. Maybe you're fortunate enough to be in remission from breast cancer, which is wonderful, but then you lose your coverage. And so it's inherent in the nature of the way we've tried, with really good efforts and, more success than I've personally had. So I'm not knocking past efforts, but to try to fill in the cracks and layer on patches to cover the places where people are missing coverage. It's precisely, that's why people are falling through the cracks. Or even if you don't lose eligibility, simply the fact that there are eligibility requirements means you have to document periodically that you still meet the requirements. In fact, I was binge watching The Pit this last couple days. And by the way, it has now become, I haven't shared this with Liran yet, but my current goal in life is to get our book discussed on The Pit, because actually all of the things they're talking about. So this particular episode was about a kid who came in with asthma because he hadn't been taking, really acute, almost died, hadn't been taking his asthma medication because they'd lost their Medicaid coverage, not because their income eligibility or any other eligibility had changed, but they'd moved, and the letter saying you have to redocument your eligibility had gone to the old address. So, anyone out there who has a connection to Noah Wiley, that is currently my goal for health insurance reform in the United States, as well as my own personal pleasure, would be to get them, to feature our book on The Pit, because everything they've been talking about this season are the types of things we cover in the book quite accurately. I mean, our book is obviously, of course, accurate as well.
Yes, I'm also watching it, and the season finale just dropped last night. I haven't seen it, so please, I haven't seen it either. So please, exactly. Okay, no spoilers. So in the book, you make this, it's obvious that the U.S., and Debbie was referring to this earlier, there's no system really. There isn't a system, and you describe in the book how no one would design what we have. If what we actually have, no one would sit down and design that. All right. So you do cover this in the book, but for our audience, how did we come to have the quote unquote system that we have today? How did this happen?
So that's a terrific question, and not just because, I personally always find, the history of social policy very interesting, but it was actually because we started with a version of that question, like, what is the goal? Well, let's see what we did and what we were trying to do. And that actually revealed to us the history of what we have been trying, albeit not very successfully, to do, I think is the secret to what it is a system needs to do, a well-functioning system. And basically what our history shows, starting from, the dawn of the Republic and, through modern times, is that as a society, when people are sick and suffering from a health condition from which we can provide relief, but they cannot afford that, we will step in as a society, as taxpayers, and provide the care that they cannot afford. Now, you might say that that's a strange statement to make about a country that, in fact, doesn't have universal health insurance. But in fact, what we see is that we have been trying to do that, and we've just been failing. And because the way we've been doing it, perhaps because of political constraints and opportunities, is to do this piecemeal. So let me give you just one example, although there are many in the book, which is an article that appeared on the cover of Life magazine in, I think, 1962, describing what they called the God Committee, a group of 7 people drawn from a cross-section of society in Seattle, who got to decide, who got a second chance at life. And this wasn't a metaphor for rehabilitation or starting your life over. This was literal life and death, because what had happened is that dialysis had been invented, right? So people suffering typically in the prime of life from end-stage kidney renal failure. This had been up to that point a death sentence unless you could get a transplant, which was, as you know more than most people because you work on this, they're hard to find a match. And what had been invented in the Seattle hospital, I think at the University of Washington, was an early form of dialysis by which a machine could function like your kidney and therefore keep you alive while you awaited a transplant. The problem was this machine was and continues to be use of it quite expensive. Most people could not afford it, and hence, the hospital trying to balance, covering its costs with fulfilling its, social mission was going to give away some amount of treatment for free. And they assigned this so-called God committee to decide who should get it, right? And there was a physician on it, there was a cleric, there was a social worker, etc. So this article prompted an enormous on the cover of Life magazine, prompted an enormous backlash against the idea that in, modern America in 1962, in this rich country, people were dying despite the existence of a life-saving treatment because they couldn't afford it. It's caught the attention of one of the senators from Washington who had a childhood friend who was on the was one of the people trying to get this. And, politics then played its way. There was, hearings. There was a dramatic moment, apparently, in which advocates wheeled in a patient into a congressional committee and dialyzed them in front of the committee to dramatize this. And ultimately, in 1972, the Medicare program, which had been created in 1965 to cover the elderly, was expanded to cover people with end-stage renal disease. So in fact, people say the kidney is the only organ with universal coverage. Like people now, if they have kidney disease or end-stage renal failure, are covered by Medicare. So that both, I think, illustrates the types of, particular issues became salient at a particular moment, and we developed there was enough of a political coalition to develop a patch for that. And in the book, we discuss many, many other examples, including HIV coverage for severely disabled children, coverage for Lou Gehrig's disease, coverage for migrant workers. The list goes, coverage for breast cancer, as I mentioned earlier, the list goes on and on. But these same actions, although they were well-intentioned and obviously did good relative to not having them, reveal the fundamental challenge. So let's take the program for end-stage renal disease. Okay, so the most obvious problem, the one that I think we were aware of before we even started working on this book, was like, why just the kidney? What about, people suffering from other chronic life-threatening diseases? But even just looking at the kidney, so to get on the program, you have to have end-stage renal disease. That means many people, and we talk about examples in the book, when they start to have chronic kidney problems, and I'm a little embarrassed using too many terms in a webinar filled with medical personnel, but my understanding is there's, a lot that can be done at the stage of chronic kidney disease before it progresses to the end stage that might prevent it from progressing to the end stage. Well, that's not covered. And then here's the really crazy part. Suppose you're fortunate enough through, the work of heroic transplant surgeons and also economists like you, Mario, are doing to arrange for matches to get a successful kidney transplant. Well, that's wonderful for your health, but that's terrible for your health insurance because now you have a functioning kidney. You no longer have end-stage renal disease, and you lose your coverage, despite the fact that you will, by virtue of your transplant, need to stay on immunosuppressant drugs costing tens of thousands of dollars for the rest of your life.
And that is the opposite of being insured.
Correct. So I think, what this history revealed to us is both the intention, this time and time again, some group that is suffering from a life-threatening but treatable and or curable disease that doesn't have the resources to pay for that treatment comes, to political salience, gets some attention, and we put on a catch. But on the other hand, that catch is imperfect, both because it doesn't cover everyone, but also even for the people it covers, it's often too little, too late, or as you said, not really insurance because it's insecure, it comes and goes.
Thank you for that summary. I really appreciate that. And I also watch The Pit. I watch it with my kids so that they can understand my job, because I think it's the most accurate representation of emergency medicine that's been done. I'm actually friends with one of the writers, so I'm going to mention your book to her and see if we can get
Literally everything on the
That's right.
second season that they've been discussing is,
Yeah.
is covered in the book. Anyway,
I've
my
thought about your
dream
book.
is that a patient comes in clutching the book. It doesn't have to be played by me. Liran can be the patient, but yeah.
I've thought of
That's
your book a
right,
lot
Deborah.
while
It
I
is
watched.
your job, Deborah. That's exactly right. So do you see yourself in the
Yeah.
situations that are represented there?
My kids are looking at me with a lot more respect these days. They're like, "That's exactly what you do," and I'll
Wow.
answer what the clinical thing is, and then it happens, and they said, "You knew that was going to happen." It's like, well,
That's
that's my day
impressive.
job.
I watch the show and I think, thank God I'm not an emergency room physician. It plays against whatever strengths I have, it plays against all of them. You have to be like calm and quick and broadly capable and like thinking outside the box. And thank God there are people who do that.
Yes,
Well,
super grateful to
it's the
Debbie
best and the
and your
worst job in the
colleagues.
world. I do appreciate the support from you all and from the pit. But from a frontline perspective, it does feel like the system is trying to do multiple things at once. Like one of the things we see in the emergency department, it's not just heroics like at the pit, but they do show some of the systemic failures that are really manifested a lot in the emergency department. And in part 2 of your book, you shift to a really important question about that you touched on earlier. We need to be clear about what health insurance is actually for. And you talked about, the idea of insurance writ large. But let me ask you directly, what is the core function of health insurance in your view? And what should a well-designed health insurance system do for people? And how does clarifying that purpose help discipline the rest of the conversation? Because it feels like we need to start there before we can figure out what to rebuild.
Yes, that's a great question. What became very clear to us when we looked at all of these past attempts at reforms, and of course we haven't touched on it, and I don't want to derail us, but of course the EMTALA, the act that says that, even if you don't have the resources, an emergency department has to stabilize you, not treat, but stabilize, right? And although they can then bill you for it, is one of these patches. What becomes clear is that we have, for want of a better term, a social contract, if you will, that we were very glad when we found a distinguished historian of medicine say it in his book, Charles Rosenberg book, The Care of Strangers, about the history of the hospital system in the United States, because it felt kind of crass when we said it, but we can quote him and say that this social contract is that people should not be allowed to die in the streets, right? And that was actually the original origin of the hospital system in the United States. It was charity care at a time in the early 19th century when medicine could not do much, to make sure that people who were ill and away from their family in the newly created cities had a place where they could be nursed and tended to. And I think that is the fundamental purpose of a health insurance system, to make sure that, basic medical care, and it's important to discuss what is and is not basic, but the basic medical care is available without regard to cost to everyone.
Let me jump in just on this and just the way kind of we want to say it is not, it's not that we think that this is the social contract or we think that's the right social contract. Some people might disagree with this, some people could agree more versus less, but the thing that comes up over and over is that whether we think it's the right social contract or not, that's the way the policy in the US and the different changes in Medicare or earlier or later have revealed, in the sense that sort of whether we think it's right or not, the way we behave, the way we make policy, the way we try to patch the system kind of suggests that sort of, that's the way policymakers kind of behave, as if this is the social contract. So it's less about a normative assessment of what's right, which we happen to also think it's right, but it's more about a positive assessment of how the government behaves, whether it's Republicans or Democrats. It's been fairly consistent.
Yeah, and that's the thing that, actually gives me some hope, which is that this principle, as Liran described it, is something that is implicitly and explicitly espoused across the political spectrum, at least the political spectrum that existed in 2023 when we wrote the book. You see this from libertarians like Charles Murray. You see this from conservative intellectual thinkers like Friedrich Hayek. You see it from the actions of Republican governors like Mitt Romney in Massachusetts, and you see it on the left, of course, as well, from progressives. So, but I don't think anyone believes that we should let people die in the street, as Rosenberg puts it, for lack of the ability to afford life-saving care. And then the key question is, if fundamentally we're going to end up there, maybe we need to start there rather than just say, well, we'll come in at the end stage, at the emergency, and build a coherent basic automatic system.
So yes, so in the book you say, look, we don't need to discuss philosophically whether or not we all agree that healthcare should be a human right. You say in practice the history of the US healthcare system demonstrates that empirically, as Liran was saying, there is a social contract in place. There is an agreement, implicit and actually in explicit too, given by the facts, that we are morally committed to provide medical care, essential medical care to those in need, regardless of whether they can afford it or not. And this is like, and then your next logical step is to say, we've been trying to do it. It's not working. We have failed as a country. If that's our goal, we have failed to achieve that goal. And so the only way to do it is to actually provide universal health insurance, period. Can you walk us through this? How to go from, again, there is a social contract, we're not fulfilling it. Here's your recipe for how to fulfill it.
Right. Well, I'd say there are two things. One is, I think what made us realize, we have to just start from scratch again is, take the Affordable Care Act, which, as I said, did expand health insurance coverage, but it mandated universal coverage. And what we learned from doing this is mandating doesn't make it so. So we need to actually have a system that's automatic, right? Like, so not you have to sign up, but automatic, everyone's eligible, no conditions, because if there are conditions, you have to then verify that you meet those conditions. And if you miss the letter saying you need to redocument your conditions, that's a problem. So automatic is key. Free is key, and we'll come back to that, I'm sure, because that's probably as close as one can come in our profession to committing professional heresy to say that, health insurance should be free and all the health care covered by it should be free, and it should be basic, right? So we need to have something that's automatic, because just simply saying people have to be insured doesn't get you there. It has to be free. And we talk about this a lot in the book. Why? But basically because, as we've seen in other countries, if you try to introduce some amount of, say, income-related cost sharing, you end up back in the same position of then having to verify income and make exceptions for people who can't afford it. So again, if we have, and basic though, and that's the part that, also is important, because this is not a blank check to every, luxury of, private room and gourmet food and experimental treatment known to man. We have to agree on what we're going to spend as a society and then how to make hard choices within those budgets. So automatic, free, and basic. And then, of course, as in every other high-income country, the ability, because many people, and we estimate that our proposal probably about 3/4 of people would supplement, the ability to supplement it in a well-functioning market, as in many other countries, if you want the private hospital room or, more freedom to choose which specialist to go to, et cetera. So I can dip into any one of those. I wasn't sure if you wanted which aspect of those or what order you want to talk about those.
Well, you touched very nicely on our next three questions. So I'm going to pull out a couple pieces. It's like we both followed the same structure of your book, and like those are the main principles, which I really appreciate. So why don't we start by asking you to elaborate on when you talk about free, you mentioned in the book free at the point of care. And what does that mean? And how is that distinct from either what we have now or what has been proposed in terms of cost sharing?
Right. So it's free in two respects. One is it's basic coverage that you don't have to pay a premium to get. But then most health insurance in the United States and in many other countries, and you can thank, or we sort of feel for basic coverage, blame economists for this, have cost sharing. So you have to pay, either a copay, $20 if you go to the physician, or a coinsurance, 10% of your bill. And the idea behind this is that healthcare, like any other good or service, demand responds to price. So in the same way that you go to the movies more if they're cheaper, you get more healthcare if it's cheaper. And this was a point economists made starting in the 60s. It seemed incredibly controversial. Many people said this is ridiculous. Nobody wants to go to the doctor. No offense, Debbie. And they only go if they have to, if they're really sick. And if they have to go, they're going to go regardless of cost. This is a crazy idea. And it turned out economists were right there. There's rigorous randomized trials dating back to the 1970s. I've done one more recently showing, incontrovertibly that when people have health insurance coverage and they have to pay less out of pocket for their medical care, they use care more, healthcare use goes up. But it turns out the implications that and by we, I mean literally not just the economics profession, but I'll put Liran and I in this bucket because we've written about this. The implications we drew from this turned out to be wrong, at least in the context of the basic coverage, not for supplemental coverage. This idea that by giving patients some financial skin in the game, it might make them think twice before they run to the doctor every time they sneeze or insist on, 3 CT scans every time they have a headache. That is a sensible procedure, a sensible position. And as I said, the empirical evidence is very clear that, in fact, if you put those copays in, people will use less medical care. The problem where we got it wrong as a profession is when it came to advising on the design of the basic coverage, right? The coverage that we have effectively committed to as a society to provide when people don't have access, regardless of ability to pay, when people don't have the resources. And the way we know we got this wrong is have now been able to see, and we discuss in the book what has happened in all the other high-income countries that have universal automatic basic coverage, and when they faced budget constraints, followed the advice of well-intentioned economists to introduce some copays or cost sharing into that basic system. So for example, in the UK, the original National Health Service, 1948, it was free at the point of care for everyone. That was a key bedrock principle. And then faced with budget constraints, they tried to introduce copays for prescription drugs, 10 pounds here or there, just to, again, make sure people are being judicious in their healthcare system, healthcare use. And what played out is a microcosm of that entire system of patches that we talked about in the US, but just for, cost sharing in the UK, which is they started to have to introduce exceptions. Well, from the beginning, you would be exempt from your copays on prescription drugs if you were sufficiently low income, right? But of course, then you have to verify income. They made exemptions for the elderly, for students, for children, for veterans, for people with cancer. The list goes on and on and on. And at the end of the day, what the current data from the UK shows is that 90% of prescriptions in the UK are dispensed to people who are exempted from the cost sharing. So that what we all have is a lot of headaches and hassles and people slipping through the cracks because, they haven't documented that their cancer is still not in remission and they need the drug, and all the sort of the issues that we have in the US that we see on the pit and read about in our book We see that in a microcosm in the UK. And that actually, the estimates are that if you actually just extended this coverage to everyone and you got rid of all these copays with all the exceptions, it's not clear it would cost that much more money, and it would save a ton on administrative costs. Because another way of saying it is we're effectively paying for a lot of care for people through the government system. We're just doing it in this piecework, patchwork way that's punching below its weight. And that's why we came out and said, look, we've been too clever by half on things that ultimately are essential, that we've decided are part of the basic plan. Let's not, create, because even these $5 or £5 copays, there will always be someone who can't afford it. We're going to have to create an exception and a workaround, and we're just going to find ourselves back in this patchwork mess. So let's be judicious about costs on the level of what is covered, but make sure that everything that is coverage is automatic and free.
Thank you, Amy. So for the next part, so you cover the automatic and the free parts of your proposal. The next part is the basic feature. So to ask this question, so first of all, we have a lot of questions from the audience. So I'm going to use one of those questions to ask about the basic feature. So this question goes, there seems to be an assumption that the definition of basic or essential medical care is obvious or trivial. Not in the book, but I guess in the debate, in the conversation. It is actually the crux of the problem. One of the reasons that, and I'm reading the question, right, that health insurance is so expensive in the US is that so much gets piled into quote unquote essential benefits driven by politics and special interests. How to address this, and more broadly, what do you mean by basic, and how do you decide what goes into the basic coverage?
This is an excellent and difficult. Oh, sorry, Liran, were you going to say something?
No, let me just take it 1 second, and then I give it back to Amy, because it ties a little bit to the cost sharing that Amy was just talking about, and to the social contract that we were kind of talking about earlier. If conceptually we're not going to give a list of what's basic and what's not, what's essential and what's not, one, it's changing over time and different people might feel differently about different things. But conceptually, what we mean by basic ties exactly to the social contract discussion we just said before. We said we don't want to let people die in the streets, kind of, and we think that's like the empirical social contract. And basically what we mean by basic is anything that we don't think that we would let people go along without doing. I mean, sort of, if you ask them to pay $5, and then because of that they can't, some people, even few people, can't afford it, and then we'll step in and tell them, hey, take the $5, just get it, because we feel that's part of the social contract. That's basic. If it means that you cannot pay the $5, and then we say, like, fine, so don't do this. I mean, no big deal. Maybe you'll have to recover longer, but you'll be fine eventually. Then that's not basic. So basic is really ties very closely to what we thought was the social contract, and what exactly it is. It's how to define, but conceptually it's very clear. It's the thing that you wouldn't let people go without, as a country, without doing. So that
No, that's very helpful. And then, from that, there become some very obvious things that are in emergency care, et cetera, life-saving surgery, if your appendix erupts, et cetera. And a few things that are obviously, I think, out, like you could say, purely cosmetic plastic surgery for no functional purpose, just to, make some aspect look better, right? And then there's a huge gray area. And we talk a lot in the book about how other countries have made these decisions. I think Liran is exactly right to say that there's no one answer. It's going to change over time. The key principle is if we're going to feel as a society compelled to create a workaround, if something isn't covered, then it needs to be part of basic. And the other key principle is that this system has to have a budget. Right? Which again, it's kind of amazing. Every other high income country which has universal health insurance also has a healthcare budget. The United States does not have a healthcare budget. When we talk about, say, the Medicare budget, we don't mean a budget in the sense of like, my household budget, which I need to stay within. We mean the Medicare budget is how much we spent last year or how much we're guessing we're going to spend next year. There's no constraint. And so you can only make these difficult decisions if you actually have a budget constraint, And then we talk about how every other country does this through some combination of technocrats estimating, doing cost benefit analysis on new treatments, and a community of stakeholders, politicians, people in society, also weighing in on, what they think is important. And if in fact more things are important than can be fit in the budget, perhaps a vote to raise the budget or a vote and taxes or spend something less on something else, or a vote to decide, no, this isn't essential. So, one of the things, we give one example in the book, which is common in many high-income countries. We talk about examples in Australia, in Singapore, I think maybe in Israel as well, where a lot of what is not covered by the basic and a lot of what you buy with the supplemental coverage are amenities, right? They're really nice to have. For example, in Singapore, the basic coverage covers a hospital bed in a ward with 10 beds to a room, and a climate that in Singapore is notoriously hot and humid climate they euphemistically refer to as naturally ventilated. And a lot of what supplemental coverage buys you in Singapore is not a different physician or a different hospital, but that when your surgery is done, you go to a private room with air conditioning, with your own bathroom, with high-speed internet, and with good food. Similarly in Australia. So we give the analogy in the book to thinking about airlines and, the budget airlines that have, sprung up in Europe, which anyone who has taken on, knows is not, necessarily deluxe accommodation. I think we'd all, especially those of us who are taller than me, prefer more leg room, free Wi-Fi, unlimited unchecked bags. But if we had a social contract that was to fly people from point A to point B, they deliver on that. And, those who want more leg room, better food can supplement and upgrade to business class. And so that's I think one of the things that many other countries do, and that seems a natural thing to do, but then you do also have to get into these difficult issues of there's a new drug that comes out or a new procedure, is it covered? And as Liran said, I mean, we don't have any particular expertise on this, and nor even if we thought we did, would we want to list everything, because not only would it make for a boring read, but it's going to be outdated. GLP-1s didn't exist when our book was written, and now they do, so it'll be quickly outdated. You need a process and a budget.
Yeah, and just one more thing is it's kind of related to what Amy said. Like we say, we don't want to let people die in the street, but if keeping someone alive requires like $1 billion in some new drug, then maybe we do, because because it's more than the value of statistical life or something like that. So it's not that like anything that saves people should be covered because it's basic. It does depend on the cost and the budget, and we cannot kind of divorce this from the economic decisions.
Yes, in the book you explain, I think very, very clearly how countries with the universal health insurance have agencies that with representative with elected officials or experts or both that are tasked with answering those tough questions. So the question of what is basic, it's non-trivial, but it's also not intractable. That's the one key thing.
I'm not naive in thinking that those countries have perfect systems, or that politics or interest groups or idiosyncratic emotional reactions, are involved, but at least they're having the discussion. We don't even have it in the US. And then it therefore happens implicitly through, whether you can find, the right, physician who's willing to accept without payment or steer you to a discount program or whatnot. So by not having the conversations, that doesn't mean we're avoiding these tough issues. We're just not discussing them.
Exactly. So, Amy, you mentioned supplemental health insurance earlier. In the book, you have a really great discussion about, a concern that some people have, that supplemental health insurance combined with the basic health insurance would create a two-tier system. And some people are concerned about that. So could you frame that discussion and tell us, which side of the debate you fall on?
Yes, so there are certainly, concerns about a two-tier system. I think, though, whether or not you're comfortable with a two-tier system, it's inescapable. We have that for everything. We have the local publicly funded police to provide for public safety, and yet, people buy private burglar alarms or live in gated communities. Similarly, we have, legal aid to provide for, public defense, and people who can afford it, pay for more expensive lawyers. So this is a fact of life in any capitalist society. I think the thing that we take very seriously is the concern that the existence of the supplemental system can undermine the essential adequacy of the basic system, right? And I think this concern shows up in two ways. One is in economic terms, that there's a limited supply of, highly trained good physicians or medical equipment. And so if some people can pay more, they're going to pull all the best physicians or best hospitals into the supplemental system and erode the adequacy of the basic system. The other concern, I think, is a political version of that, which is that if you have enough high-income people in the supplemental system, it will erode the support for adequate funding for the basic system. So in both cases, our concern was not with the existence of a two-tiered system, because as I said, I think that's unavoidable, but the concern that the existence of the second tier would undermine our fulfillment of the social contract to make sure that the basic system is in fact adequate and is fulfilling, is providing all care that it's deemed essential. And we give examples of the book of countries, particularly in Latin America, where that has basically happened, where, there is, a public universal system, but it's considered highly inadequate in some countries, and people who can't afford it go into the supplemental. And we give examples of other countries where they've managed to strike this balance quite well. And even countries like Australia, where the government actually encourages via tax subsidies individuals to buy into the supplemental system because they feel that injects more money into the hospitals, which can then be used to cross-subsidize the public system. So I think, our solution, which is going to sound kind of like a cop-out for economists, but it's basically a political solution. It's, to quote the ACLU, eternal vigilance is the price of liberty. It's also the price of universal health insurance coverage. What you need to be monitoring whether or not the basic system is adequate. And if, wait times get too long, and we talk about examples even in the US where the Veterans Administration has, and Congress has decided what is too long, what is not. And then you have to do something. You have to increase funding or cut back on other benefits and that you decide are not essential. And we give examples of countries like Israel that have, done this periodically. So it's an important question. It's a real question, and we don't have obviously we can solve that, but it's an inescapable feature. And by setting up good systems, we can try to stay on track of it. But it's an incredibly important issue for sure. I mean, just to be clear though, like the way we imagine this happening is if you have this automatic basic system, for many people, it could happen in a way that their current insurance is not really changing at all. And so it's just about, formalizing what we've been implicitly doing for the uninsured and making sure it's there when they don't have that, supplemental private or additional public coverage. So we think it is feasible.
Well, that segues us to what I think is our last formal question. We do want to leave a few minutes for audience questions, and this will be a quickie because it's about the politics. I'm sure you'll have this one handled really quickly. So to talk about the political dimension briefly, is anyone today really fighting this battle? And as we were preparing for this webinar, I actually just saw the other day that Maryland passed a law just this year. It's about to get signed by the governor, passed a bill to form a commission on reimagining healthcare. And I was like, I'm going to bring this book to the people on this commission and say,
Awesome.
reimagine it with this as a starting point. So is anyone really fighting this battle? And do you think this is sort of a segue into, because of the Maryland bill, do you think this can be fought on a state level, or do we really need federal buy-in to get?
I think it can totally be done on a state level. And in fact, the history of most policy in the US, as well as most health policy, has been, the states as laboratories of democracy. They experiment, in fact, the Affordable Care Act, the Massachusetts Romney Care was in some sense the prototype for it. So we would be thrilled for any state or the federal government to take this seriously. And we tried very hard in the book and a bit in this conversation to be clear are the key principles, but there are many aspects where, either we don't think the evidence is there to tell us which way to go, or depending on preferences, you could go different ways. So as I said, automatic, free, basic coverage with the ability to supplement. But, is that, multiple private insurers with or without a public, insurance system? Is that a single payer system? Do people keep their employer provided health insurance if you want? Those are details. They're incredibly important details, but there are many different ways that we can fulfill this social contract because we see that in other countries. We see things like the UK, which is, a single payer, physicians are employed by the government, soup to nuts system. And you see places like the Netherlands, which have competing private insurers providing the universal basic coverage and the supplement all in one. So there are many, many different paths to yes, depending on people's views of the right policy or the right politics, as long as we retain the core principles.
A quick question, staying on the politics for a minute. So, if someone, I think if an alien or a human being with no knowledge of U.S. history were shown, like here's the U.S. healthcare system, okay, I think their first thought would be, there's no way that this country is going to enact universal health insurance coverage, okay? Instead, in the book, you make the opposite argument that it almost happened, that it's not in. So why don't you walk us through that part of the book? I'm trying to end on a note of, on an optimistic note here.
Yeah. So let me caveat this before Liran jumps in and does it and says, politics is not our lane, right? So we deliberately left it to the end. Our goal was to articulate what we thought a system that met the core needs would look like and how it could be economically feasible, and to leave it to others on this webinar and elsewhere who are far more skilled than we are, and presumably also skilled on an absolute basis, to think about how you package this, politically or in policy circles. That being said, what we do end the book on is that, our read of history is that the narrative that the US was destined to never have a universal health insurance system because the AMA is too powerful, the labor unions are too powerful, we don't have class consciousness, pick your favorite reason. And the parallel narrative that meanwhile in every other high-income country it was destined to happen, that the British, forged in solidarity after withstanding the Blitz, were going to, rise up to form National Health Service. Neither of those is an accurate reading of history. As you mentioned, and we talked about in the book, the very near misses we had, like in the early 1970s, when both the Democrats and the Republicans had competing proposals for universal coverage on the floor of Congress, and the very, very bitter debates that preceded national health insurance coverage in both Canada and Britain, including, a strike of doctors in Canada, et cetera, et cetera. So I think, I don't know exactly how we're going to get there. I think that states are one possible way to start, but I think it is a misreading of history to say that we were destined to never have it and that other countries were destined to have it. And our hope in writing the book was to sort of articulate the North Star of where we believe we need to get to so that other people can figure out how we get there.
So we have so many good questions in the chat, and this has been such a great discussion. I really appreciate everybody's time. I want to say a lot of the questions that are in the chat are really well answered by the book, which I own in paper, Kindle, and Audible format. So I do strongly encourage everybody to read it because we're not going to be able to get to all of these questions. And Amy, I feel like I'm setting you up a little bit by choosing Robin's question because you just said you're not the person to answer it, but I still feel like you've given it a lot of thought. So can you share thoughts on how our current system could transition into the type of system you're recommending? This is, again, a question from the audience. Relatedly, curious about the challenge of health insurance being connected to employment and the role of private health insurers in the US. And I think that the private health insurers' role is one thing we haven't really touched on yet today.
Yeah, let me take the second question first on the role of employers and private health insurance. So first, as I said, we can fulfill the core principles that we need to for the social contract with private health insurers and public health insurance, with just public, with just private. So those are choices that can be made based on policy or political grounds. There is a view in the real world that, employer provided health insurance is can't be touched politically. If that's true, there's no reason one couldn't enact our system preserving employer provided health insurance. Personally, as economists, we think there's a lot of problems with employer provided health insurance, but that's separate from our book. The easiest way to think about how that could be done is think about something like the current private Medicare Advantage version of public Medicare, right? Where every 65-year-old is automatically guaranteed health insurance coverage through Medicare. People can, if they want, and now about half of them do, opt out into a privately run insurance plan, Medicare Advantage. And if they do that, the government essentially gives the private insurer a voucher that says, we thought we were going to have to pay about this amount every year to cover Debbie with Medicare. You want her, you take her. Here's what we would have spent on her. You got to make sure you hit the following, coverage criteria. One could do the same thing, and then people can top up within Medicare Advantage. One could do the same thing. If you had our system, everyone has this automatic coverage, but you want to opt out into your employer provided system. Your employer gets a voucher equal to what the government would have spent on the basic care. The employer has to cover with no cost sharing, anything guaranteed by the basic coverage, and then can cover additional stuff as well. So maybe that also answers one way the transition could happen as well. But again, we try to be very clear that there are many different ways the final system could look, subject to our basic principles, and many different ways to get there. So, I just sketched one that tried to address the question of private health insurance and employer programs.
And with apologies for staying a little bit more on the politics, there's one question from the audience that I found sort of interesting, and the question is this: many people thought that Obamacare was the answer to the problem we are discussing. How has it failed to achieve that purpose?
Yeah, let me be clear. Obamacare accomplished far more than I've ever accomplished in my life. So I don't mean to denigrate it, right? It dropped it increased the number of people covered by a huge amount. But I think the reason it failed, and this very much, failed or did not reach the intended goal of universal coverage, is precisely because of this is what part of why Liran and I decided we really do need to reboot. We need to start from scratch. It's because it was layering on solutions to the existing system. There are people who weren't eligible for health insurance. So now we're going to mandate that everyone have it, and we're going to try and make it affordable by making it free if you're below 138% of the poverty line, or heavily subsidized in the next range. And forget even the states that didn't expand Medicaid. Even in the ones that did, there's these startling statistics that a large share of the uninsured are in fact eligible for free or highly subsidized insurance, but they don't have it because either they're not aware of which program they're eligible through, or they didn't file the paperwork, or they didn't re-up the paperwork. So simply saying everyone has to have it and we're going to make it affordable, turns out, we have now learned, is not sufficient to get to universal coverage, which is why we need to do it the way we did Medicare in 1965, at least for hospital insurance, automatic, right? no, you don't have to file any paperwork, right? It becomes automatic. You know, we know when you're 65 because of the Social Security system, and you're automatically covered. And we just need to do that for all ages.
Beautiful. We've got you covered. Rebooting American healthcare. Thank you, Amy. Thank you, Liran, so much for a really great, very informative conversation. Also, thanks to our audience. Please go to our website, HPHI's website, where you can see our future seminars and also find links to YouTube recordings of our past webinars. Debbie, it was a pleasure co-hosting this with you.
Yes, let's do it again soon. Thank you all so much.
Thank
It was a
you
wonderful
both so
Thanks for
much.
Thank
having
you
us.
again. Thank you so much.
Bye-bye.